Welcome to this video on recognizing and managing two critical, look-alike overdoses, calcium channel blockers and beta blockers. Both ingestions can present with profound bradycardia and hypotension, but their underlying mechanisms differ. This video will provide a bedside framework for distinguishing between them and guiding your management. Our roadmap covers 5 key objectives: recognizing the clinical overlap, applying a structured diagnostic framework, using glucose as a rapid discriminator, reading the ECG to distinguish patterns, and properly sequencing your therapeutic interventions. Why does this matter? These two toxidromes share a final common pathway of shock, making them difficult to tell apart on arrival. Because the antidotes differ, identifying the underlying mechanism is essential to avoid wasted time. A bedside glucose check often provides the fastest initial clue. At a glance, both drug classes target cardiac conduction and contractility. Calcium channel blockers like verapamil and diltiazem primarily impair calcium-mediated processes. Beta blockers, including propranolol and metoprolol, inhibit beta-adrenergic receptors. Understanding these mechanisms is the foundation for effective treatment. The diagnostic challenge arises because both toxidromes converge on profound bradycardia, hypotension, and cardiogenic shock. To differentiate them, use a structured approach. Assess mental status, check point-of-care glucose, analyze the ECG intervals, and perform a focused respiratory exam. In terms of mechanisms, calcium channel blocker toxicity blocks L-type channels, leading to impaired contractility and insulin suppression. Beta blocker toxicity blocks adrenergic receptors, decreasing CAMP and blunting the catecholamine response, which is crucial for glucose regulation. Regarding mental status, calcium channel blocker patients are often awake and alert unless shock is severe. In contrast, lipophilic beta blockers like propranolol can cross the blood-brain barrier, causing coma or seizures even when blood pressure is relatively maintained. Glucose can be a key clue. CCB toxicity is classically associated with hyperglycemia due to impaired insulin release from pancreatic beta cells. Beta blocker toxicity can lead to hypoglycemia because it blunts the catecholamine-driven response necessary for gluconeogenesis. Your ECG analysis is vital. CCB overdose typically shows sinus bradycardia with a prolonged PR interval, while the QRS usually remains narrow. Beta blocker overdose may share these features, but membrane-active agents like sotalol can cause QRS widening or QT prolongation. Other distinguishing features include the respiratory exam and skin perfusion. Beta blockers may cause wheezing, whereas CCBs rarely do. Dihydropyridine CCBs might paradoxically cause reflex tachycardia, unlike the persistent bradycardia seen with most other agents in these classes. This master table summarizes our findings. Use this as a quick reference for mechanism, mental status, glucose patterns, and hallmark ECG findings. Note that while antidotes differ, high-dose insulin euglycemia therapy is a shared mainstay for both types of toxicity. Management starts with shared first-line therapies. Provide judicious fluid resuscitation and consider an early trial of atropine, though it is often ineffective. Start high-dose insulin euglycemia therapy early and utilize norepinephrine to support perfusion. For specific escalations, use IV calcium for CCB toxicity. For beta blocker toxicity, consider glucagon and lipid emulsion for refractory cases involving lipophilic agents. If patients remain refractory to all pharmacologic interventions, consider methylene blue or early consultation for VAE-CMO. Follow this algorithm to guide your care. Start with shared first-line stabilization, then use clinical clues to differentiate between the two. Never wait for a definitive diagnosis before initiating supportive care and early insulin therapy, as both are life-saving. Finally, avoid these common pitfalls. Do not rely on atropine alone, and do not delay high-dose insulin therapy. Monitor glucose frequently, remember the risk of sustained-release preparations, and always call your local poison control or toxicology center early for guidance. This quick-look bedside card summarizes the essential differences. CCBs often present with hyperglycemia and preserved mental status, while BBs may cause hypoglycemia and profound CNS effects. In both cases, initiate high-dose insulin therapy early, and remember, never delay resuscitation to confirm the specific culprit. Use these case vignettes for your group discussions. Analyze why the clinical picture in Case 3, an intentional overdose of both agents, is ambiguous, and discuss why immediate, shared first-line therapy remains the priority even before you have confirmed the underlying cause. For further study, refer to these primary toxicology resources, including Tintinallis and Gold Franks. Always consult your local poison control center for real-time dosing guidance. Remember, this framework is designed to supplement, not replace, your institution's specific clinical protocols.